Welcome, colleagues. We're just going to admit media that are coming on, and we'll start very, very shortly. Thank you for joining us today. We hope to start on time exactly at 12 o'clock, so we'll just wait to admit everybody and then we'll start. Good afternoon, colleagues. Thank you so much for joining us today in this segment of Decoding the Science with the National Institute for Communicable Diseases. The NICD is a division of the National Health Laboratory Service, and we have invited our experts here today to engage with you and to answer your questions that you might have with regards to COVID-19 and with regards to the multinational outbreak of monkeypox. So the NICD's focus is really on research, surveillance, spatial diagnostic, as well as training with regards to communicable diseases. We work with different types of diseases, such as tuberculosis, HIV, meningitis, respiratory infections, hospital infections. But today we really want to focus on COVID-19 as well as monkeypox. So I'm here today with our Executive Director, Professor Adrian Purin, who will also be assisting with your questions that you might have, and he's here to really engage with you today. We also have Professor Cheryl Cohen, who is the Center Head for Respiratory Pathogens as well as meningitis. We also have Dr. Jacqueline Weyer, who's from the Center for Zoonotic Diseases here at the NICD. So before we start, I'll just like to ask Professor Adrian Purin just to greet everybody and welcome the media colleagues. Over.
Thanks, Sin and thanks Cheryl and Jacqueline for being available today. And welcome to you colleagues in terms of this particular Decoding the Science, which I hope you'll find interesting and exciting. It's two contrasting epidemics. One is the ongoing one, as we know, COVID-19, and obviously great focus on the multinational outbreak in terms of an endemic virus in circulation in certain parts of Africa, and what does that hold in store for us. And I'm looking forward to Cheryl telling us a bit more where we are with regard to the current outbreak, and then focus on Jacqueline in terms of the monkeypox. It's an unfortunate naming, but those are the conventions that are used, but I'm sure Jacqueline will will expand on that a bit more. So thank you, and look forward to your comments and questions. Thanks, Zinatla.
Thank you so much, Prof. Prof. Cohen, if you could please just pop up your presentation, and I'll just hand over to you to just let us know what is happening on the COVID front. Over.
Thanks, Sine, and thanks everyone for joining today. Can I just confirm that my screen, you're seeing the correct screen, and you can see me and hear me?
We are, yes.
Okay. So great. Thanks for the opportunity to really give an update on COVID this morning. And so as you can see here, that the title is really an update. And so I've got a number of slides, and I'll go through them fairly quickly because I think most of the audience is very familiar with the way we present the data. But I think it's a very good time now to really be getting an update as we seem to have just passed the peak of this recent resurgence that we've been having in South Africa, and as we move into the winter season. So this is just the update in terms of the number of laboratory confirmed cases. You can see here on this graph the 4 big waves that we had. This was the original first wave. Then we have the second wave, which was the beta variant, the third wave, which was the Delta variant, and then the fourth wave, which was Omicron. And we see how with the Omicron, it didn't come down as low as the levels we saw between the other waves. It sort of carried on going. And we think part of that was because Omicron itself is not just one variant, but there's a whole lot of subvariants in the Omicron family. And some of these subvariants have immune escape. So the original Omicron was what we call BA.1. And then this little shoulder was associated with another subvariant called BA.2. And then more recently, we see this resurgence. And I'll show you, I've got slides on it later, which was associated with another subvariant called BA.4 and BA.5. And as you can see, we've had this recent increase, and I think there have been a lot of cases. Almost all of us, even if you're not in the medical community, will know of people who have been sick in this last wave. But what you can see, and what is very reassuring, is that it now appears that the numbers have started to go down. There was a 27% decrease in cases since last week, and in fact for 2 weeks now we've seen a sustained reduction. And what's also heartening is the absolute numbers here on this slide are much lower than in the previous waves, although and I'll show you now, we think a lot of that is actually driven by testing and changing in testing practices. So this is just showing the incidence of lab confirmed cases by province, and you see exactly the same picture as the previous slide, just with different colors for the provinces. In that in all provinces, really, this last resurgence was at a much lower level than we see in this previous waves. And in fact, in all provinces, we're seeing a reduction in cases, and now except the Northern Cape province, the cases are still going up. But I think that's just because it was lagging behind. So for example, Gauteng, which was the first affected in this resurgence, has been going down for longer than the others. So the provinces, some of them just start a bit later, but essentially in most provinces, we're now seeing a reduction in cases week on week. This just shows it by age group. And I think what is interesting is that the highest number of cases are actually in the elderly, the over 80s, and then the 40 to 59-year-olds. And I think this is largely reflective of the fact that in this resurgence, the people who are testing are mostly people who are actually quite ill. And we know that you get the more severe disease in the older age group. So it probably is reflecting testing patterns more than, in fact, who's actually infected. And just to go on a bit more on the testing, this is the testing, and you can see here that if we look at these lines, which are the number of tests, you can see how the testing rate, while it has gone up more recently, it really hasn't gone to a very high level. So I think we are seeing some fatigue in terms of people presenting for testing, especially if they've got mild illness. We also know that people can now often access rapid antigen tests that they can do at home, which may not be reported as consistently. And so I think what's important to note is that the total number of cases that we're seeing in our database, we know is not reflecting all the cases that are in the population, and probably more, of course, if you're more severe, and certainly if you're admitted to hospital, though, you will get a test. And so those indicators, and I'll show you them now, the admission indicators are probably a bit more robust. Looking at the percentage testing positive, though, what's interesting is that even though the testing didn't go up, the picture with percentage testing positive here, it actually went quite high with a 26% peak. But what's, again, reassuring, and all the indicators really show the same thing, this reduction now for the last 2 weeks, suggesting that cases are now coming down on a national level. If we look at testing by age group, this just supports what I was saying, that certainly in this wave, it's really older people who are much more likely to test. And that's partly then rolling on to the age distribution of diagnosed cases is more in older individuals. And we see this on the right-hand side also, where the percentage testing positive right now is high in the 70 to 74 years age group. So unlike at the beginning of the Omicron wave, and especially here, this shoulder is much more, this is actually, 10 to 14. This is much more kids, but I think here you see that all ages are now affected. And so I think, just to highlight though that with cases, it is affected substantially by who tests, and we know not everybody tests with symptoms. This is just a recap on the genetics and also an update on what are the important variants and subvariants that are causing this current resurgence. And you can see here from this is beta, and then the green is delta, and when we get to the orange colors, that's all the Omicron. And you can see here initially the BA.1, which was our first Omicron wave starting already last year. And then you see this emergence of the subvariant BA.2, which we think accounted for that shoulder. The reason that the cases didn't come down completely was because BA.2 offered some immune escape. And so people were getting infected with this. And then as the BA.4 and BA.5 have become increasingly important in terms of contributing to cases, we've seen this resurgence. And there's other data that really suggests that these variants do confer immune escape potential. And so this would explain why people are not protected, even if they've had a vaccine or previous infection, they're not very well protected against infection. Although I'll show you now that they are to a large extent protected against severe disease and mortality. This is the same data, just showing the pie charts for March. We had BA.2 predominating. In April, the BA.4 and BA.5 came up. And then in May, overwhelmingly, the most common is these BA.4 and BA.5 subvariants. And now moving on to the hospitalizations and mortality. And just to reiterate that these numbers are much more robustly ascertained, because in South Africa, really everybody who's admitted to hospital with a respiratory illness, either in public or private sector, should be having a COVID test. And we know there's very wide access to COVID testing. So while mildly ill people may not be coming forward and testing, we think that overwhelmingly most people who are admitted to hospital will be having a COVID test if it's indicated. And so the trends that we see in the hospitalizations data, are really much more robust. And what we see here, so just to highlight, the black line is the cases, the gray is hospitalizations, and the red is the deaths. But just to highlight, there are different axes. So this is not showing the actual amount because each one is adjusted. But I think the most important thing to note is that already in the BA.1 Omicron, we saw this disconnect between cases and hospitalizations, and the hospitalizations being much lower. And we see this even more. In this recent resurgence, you can see the hospitalizations really came up to a much lower peak than we've seen in any of the previous waves. And this is likely as a result of that, although people are being infected, the fact that many people have been vaccinated or had previous infection is giving them some immunity, which means that they are much less likely to go on to be admitted to hospital or to die. And you see here in the red, the in-hospital deaths, and there's a small increase in mortality. This variant is not completely benign. There are people admitted to hospital. There are people who have died, but the magnitude of it is lower than what we've seen, certainly in the first 3 waves. And this is just the same data by province, really showing the admissions in the more higher incidence provinces and the lower incidence provinces. And just to highlight that the trend in all of these is starting to show a reduction in admissions, just as we saw a reduction in cases. Just to mention, some of this could be lags in reporting, and admissions do take a bit longer to come down than cases, usually about 2 weeks. And so, we may need to wait a little bit longer to see these consistent reductions, but right now the trends look as if, the cases have started and the admissions have started to come down. And this is just showing again by age. Amongst the adults, the over 65s are still the most affected, and in the children, it's the less than 5-year-olds, and that's not different from what we saw in the beginning of Omicron. And this is the deaths in hospital. I think you've seen it again. So this is just again to show it by province, very much similar trends there is an increase, but it's the magnitude is much lower than previous waves. And this is data from the South African Medical Research Council, one of the more robust data sources on mortality. This is all cause deaths in South Africa, so deaths of any cause. And you see the orange line is what we expect to see in the absence of COVID, and the black line is what we are seeing. And you can see these very big peaks in the previous waves, and you can see here there is an excess mortality with this resurgence, but it's certainly of a lower order of magnitude than what has been in previous waves. Again, these numbers are not coming down yet, but these are quite a bit lagged, and so we do need to allow time for the data to come in. So in summary, so we did see these increasing numbers from April, but now we are seeing consistent reductions in the percentage testing positive, in the numbers of cases, and also in admissions in the majority of provinces. That in this resurgence, the testing rate was low compared to previous resurgences, and this is likely affecting the numbers of cases. And we are likely substantially underestimating cases, but we think the admission data is much more robust, and we do see an increase in admissions, but at a much lower level than in the past. And then important in age, it's really the elderly that are most affected with severe disease, and of course people with underlying illnesses. And these are the people who need to certainly make sure they've been vaccinated, and also take extra precautions right now to avoid infection in terms of avoiding gatherings and masks, etc. BA.4 and BA.5, these two subvariants of Omicron, which do confer immune escape, are likely the reason for this increase that we've seen and now coming down. And then waning immunity can also play an important role, particularly with previous infection. People who were infected a year ago or so may be susceptible to infection again. So really just acknowledge many partners who generate all of the data for our surveillance, and the sequencing data is from the NGSSA network, which has contributors from throughout South Africa. Thanks, and happy to take questions.
Thank you so much, Professor Cohen. This is very interesting. So colleagues, you're welcome to send us your questions via the chat. And if you want to verbally read out your questions, you're more than welcome to raise your hand as well. Professor Cohen won't be staying for the whole presentation, so now is your time to ask your questions. I've got Dennis Delport. Dennis, please introduce yourself and which media house you're coming from and your questions. Over.
Hi, my name is Dennis Delport. I'm from Netwerk 24 and Beeld newspaper. Professor, I just want to know, seeing these data and the declines in cases and hospitalizations and deaths, does that mean South Africa is exiting the 5th wave of infections? Thank you.
So thanks, Dennis. I think I'm not sure it was ever really the 5th wave. I mean, you can see how it wasn't really it wasn't certainly at the level of any of the previous waves that we've had, but it does. So the early indications do seem that consistently the cases are going down, and also we're beginning to see that trend in admissions. And so it does look as if this recent resurgence we've seen is coming to an end. Now, I think what I've learned over the last 2 years is, you cannot know what COVID will do, right? In other words, there could be a new subvariant or a new sublineage or something could change that could cause the cases to increase again. But barring such an event, which is very, very difficult to predict, yes, I think that it's a positive sign, and that we would expect, unless something like that happens, that ongoing now cases and hospitalizations would continue to reduce. And I think if that does happen, that would be very reassuring and a very positive sign, because what it suggests is that although there are variants and they are able to circulate, certainly the broader health system impact does appear to be less.
Thank you, Prof, and thank you, Dennis, for that question. I don't see any other hands. Colleagues, you're more than welcome to raise your hand or put your question for Professor Cohen on the chat. Okay, I'm just still checking. No, it looks like we don't have any questions at the moment, Professor Cohen. Oh, here's one. This is from Alexander Winning. Says, good afternoon. he has a question on monkeypox. So we'll be taking questions on monkeypox after the presentation by Dr. Jacqueline Weyer. So we'll hold it for now. Thank you. Yeah, I'm just making sure we're not missing anyone with questions. Professor Cohen, we do not have questions at the moment. It looks like everybody is ready to move on to the next presentation on monkeypox. Colleagues, if you do, however, have COVID questions, you're more than welcome to email me. I'm going to put up my email address on the chat as well, but most of the colleagues already know it. And then I'll direct these to Professor Cohen, who'll still be happy to answer your questions. We'll also send out a recording of this session, as well as the presentation by Professor Cohen. Professor Cohen, thank you so much for making time to chat to us this afternoon. Thank you. Okay, so we will move on to the presentation by Dr. Jacqueline Weyer on monkeypox. Dr. Jacqueline Weyer is from the Center for Emerging Zoonotic and Parasitic Diseases here at the NICD. She'll be chatting to us about the multi-country outbreak of monkeypox. Over to you, Dr. Weyer.
Thank you, Sine. Thank you for the opportunity to discuss with you this very current event and a very different event from our experiences with COVID-19. So this is the multi-country or multinational outbreak of monkeypox. Let me see if I can move my slides. There we go. So I just want to start off by sharing some key messages. And what I'll try and achieve in this presentation is really to give you some more background about what we do know about monkeypox and our experiences with monkeypox previously, and also to provide a situational update of the current outbreak event. So as you know, there's a multinational outbreak of monkeypox, which was reported in May 2022. The situation is quickly evolving, and cases have now been, cases have now been recorded in several European countries, the United States, Canada, and in Australia. The outbreak is linked to international travelers, and we see community-based spread. The source and the linkage of most of these cases are still under investigations. Up to date, no fatalities have been reported. This is the first outbreak of monkeypox to involve cases simultaneously reported from various non-endemic countries around the globe. So this is what sets it apart from what we've seen before. And it's also already the largest outbreak of monkeypox recorded outside of the endemic countries. So the goal for us is really to perform effective surveillance through case investigation and contact tracing, so that we can break the chains of transmissions of this virus and therefore interrupt the outbreak. On 25 May 2022, at this hour, there's no suspected or confirmed cases of monkeypox in South Africa. So a situational update of the current outbreak event, and this is data that I've accumulated from different sources, and it's up to date up to yesterday. So currently, 19 countries either reporting confirmed or suspected cases of monkeypox. We are seeing reports of about 240 cases, of which 160 have been laboratory confirmed. Only 24 of these cases have been hospitalized to date, and this is really not because the patients need specific treatment, but that the decision was made to hospitalize these patients to aid in the isolation of these patients. So this is usually a decision made by the patient and the physician that's taking care of that patient. So 110 of the confirmed cases are male, and they are in the age range of 20 to 59 years. There are links for transmission for some of these cases in males that self-identify as men having sex with men. And we are also seeing links with large gatherings in Antwerp, Madrid, and in the Canary Islands, which are implicated as super spreader events of the outbreak. Up to now, 11 of the laboratory confirmed cases have been further characterized. And we can see that these viruses all belong to the Western African lineage. Now, I'm going to tell you more about that and what the implication of that is in one of the next slides. So just in summary, for the cases reported to date, so suspected cases, you can see on the screen in Argentina, Austria, Belgium, Canada, Canary Islands, the US, and this morning I saw a report of a suspected case from Morocco. Confirmed cases, you can see the numbers in brackets following the country name. Australia, Belgium, Canada, Canary Islands, Denmark, France, Spain, Germany, Italy, Netherlands, Portugal, 37 cases, Spain, 40 cases, Sweden, Switzerland, and then in the UK, 57 cases. One confirmed case in the US. Let me tell you a little bit more about monkeypox. This is a virus that we've known for many decades, and maybe this can help you to just understand a little bit better where it comes from. So monkeypox is caused by the monkeypox virus, and it belongs to a group of viruses called the orthopox viruses. And you can see there on the screen, there's an electron micrograph. Remember, we can't see viruses under normal microscopes. We use electron microscopes to see them because they are so small. So this is what this guy looks like under the electron microscope. So interestingly, there are more than 80 different pox viruses known to science. And these pox viruses infect a great deal of different species, including mammals, different mammals, birds, reptiles, insects, and of course also man. So 2 pox viruses have only been reported or are only associated with human disease, and this includes the smallpox and the molluscum contagiosum virus. Now, the good news is that smallpox is long forgotten to us. It was eradicated through mass vaccination by 1980. Human infection is, however, possible through spillover from other pox viruses from animals. So we call this a zoonotic infection, an infection that is transferred from animals to humans. And the pox viruses that do that includes cowpox, buffalo pox, a strange one called ORF, and also monkeypox virus, which we are discussing here today. As I've already mentioned, monkeypox is a viral zoonotic disease that is endemic or naturally occurring in the tropical rainforest areas of Central and West Africa. And every now and then there are exported cases, and we will look at those exported cases other than the current event, the exports that I've seen before. So the endemic countries, or the countries that naturally or have natural transmission cycles of the virus, includes the Democratic Republic of Congo, Nigeria, Central African Republic, Cameroon, Ghana, Sierra Leone, Liberia, South Sudan, and Cote d'Ivoire. What's also important, remember I spoke about the West African lineage before, and the current outbreak seems to only involve the West African lineage. So there are 2 different genetic lineages. So when we sequence these viruses, the DNA of these viruses, we can group these viruses into 2 separate entities. And it's the viruses that come from Central Africa, mostly the Congo Basin. And this is also the more severe form of monkeypox, and it's associated with slightly higher case fatality rates, and it seems to be anecdotally at least more transmissible. So currently we are dealing with the Western African clade with a lower transmissibility rate and a lower fatality rate. So if we look at all of these countries that are endemic, you get the Central African lineage in Central Africa, the West African clade within West Africa. Cameroon is the midpoint, and Cameroon harbors both of the clades of virus. On the screen, you can see a map showing the endemic areas, and in purple, exported cases that were reported before the current event. So also just to further make the point that we've known monkeypox for a long time, and although it's still rare if we compare it to many other human diseases, it does continuously occur in endemic countries. So these are the statistics from 4 of those countries for the first couple of months of 2022 and before this current event. So you can see reports from Cameroon, Central African Republic, more than 1,000 cases from the DRC, and look at that case or the number of fatalities. So remember, I just mentioned that the clade of monkeypox that occurs in this country is more fatal than the Western African one. And then cases in Nigeria as well. So what do we know about previous monkeypox outbreaks outside of the endemic countries? So before the current event, there were 7 instances of exportation of monkeypox in different ways. It happens in 2 ways, either through exportation of animals from endemic countries to non-endemic countries. And there were 2 instances where this was noted. And then in the other cases, it's always travelers to an endemic area returning to a non-endemic area. So the first encounter we had with monkeypox was back in 1958, and this was in Denmark. And this was actually when the disease was identified for the first time. And it was noted in monkeys that were exported from Africa and used for research. So this is also where the name monkeypox comes from. Monkeypox actually is not necessarily a disease of monkeys. It's actually been isolated from a fair number of different mammalian species, including different rodent species from Africa. And we'll have a quick look at that shortly. The very first encounter following this was quite a big outbreak involving 71 cases in the US. And this followed the exportation of a large group of animals, specifically from Ghana. These animals were co-housed with prairie dogs, which is not an animal that we know here in South Africa. And all of the human cases were then linked to exposure to the prairie dogs. So at some point in the supply chain, the prairie dogs were co-housed with these animals that were imported from Ghana. They were then distributed to different pet shops and suppliers across the US. And the individuals that were then had contact with those animals, either buying them as pets or dealing with them within the trade environment, developed monkeypox. Note that 100% of those cases had a full recovery. In 2018, and you can see now as I'm reporting the remainder of the exported cases, you can see the frequency of monkeypox exported cases increasing. A case in 2018 involving a person returning from travel in Nigeria. This individual actually reported direct contact with rodents, two dead rodents that he actually removed from his lodgings. He threw them away in a trash can and didn't make anything of it, of course. He developed monkeypox upon his return to Israel. There were no secondary cases noted in that instance, and the person fully recovered. 2018, there were actually 2 separate events, so 2 unlinked cases from Nigeria to the UK. With one of those cases, there was only 1 secondary case in a healthcare worker. All 3 cases recovered. Singapore in 2019, again, Nigeria to Singapore, no secondary cases, 100% recovery. In USA, also 2 different events, a person returning from Nigeria to Maryland, no secondary cases, 100% recovery, and a second introduction in the US, in Texas this time, also a person returning from travel from Nigeria, no secondary cases, and 100% recovery rate. So let's look a little bit at the transmission of the monkeypox virus. And it can be transmitted, of course, in two ways. First, the zoonotic transmission. So that event that allows for the virus to jump from the animals to the human population. And then we will also talk about the person-to-person transmission. So for zoonotic transmission, you really need very close contact with infected animals. So this could be bites, scratches. We also think that the bushmeat trade could be involved in some instance. Definitely the slaughtering of animals, dealing with the meat and the blood and the materials. Eating of inadequately cooked meat could be a risk factor because pox viruses are actually quite impervious to environmental changes. So partially cooked meat could be an issue. And then, of course, animal-derived products. If you think that this is an infection that causes skin lesions, the skins, the leather, and similar products produced from animals could also transmit the virus on. So you can also be, the zoonotic transmission can also happen when there are materials that are contaminated by infected animals, for example, linen or materials in and around the house that an individual then have contact with. What's interesting about monkeypox, and I already alluded to this, is that monkeys are definitely not actually regarded as the reservoir or the natural host of the virus. And there are many other animals that have tested positive for monkeypox before. Most probably one of the rodent species, probably the rope squirrel, it's in the picture at the top of the slide, is most likely to be the natural host. So what I mean with that is that the virus continues to circulate in nature through transmission in this species of animal. Every now and then, the virus either jumps to other animals or to the human population. So you can see there, although it's named monkeypox, it doesn't have that much to do with monkeys at all. Then if we look at person-to-person transmission, person-to-person transmission really requires close contact. This is not a virus that's highly transmissible from human to human. It's not at all the same as the flu virus or, for example, SARS-CoV-2, which is the virus that causes COVID-19. You do need prolonged face-to-face contact. There's a possibility of large droplet transmission. So again, very different from other viruses that spread via the respiratory route like COVID-19 or flu. Kissing can be a route of transmission. Individuals that have monkeypox may have skin lesions on the mouth or inside the mouth. So you can think that that could be a source of infection to others. And then, of course, there's also the possibility of transmission through sexual contact. Contact with materials that are contaminated with the virus, as we've mentioned, with the animal component as well. So this is when you have contact, for example, with linen, towels, other bedding, clothes that has been contaminated by a person that's infected with monkeypox. This could also be a route of transmission. The virus enters the body through broken skin, through the respiratory tract, or through the mucous membrane. So that's all the wet spots, the eyes, the nose, and the mouth. Those are the entry points of the virus into the body. What happens to a person that's infected with the virus? So following exposure, there's an incubation period of let's say a week to 2 weeks, 6 to 13 days, but the range is lower limit 5 days, upper limit 21 days. The infection is then, or the progress of the infection is then divided into 2 periods. Firstly, we see the invasion period, which lasts typically from like the day of onset, so for less than a day to 5 days, where patients may suffer from fever, intense headache, swollen lymph glands, so under the arms, in the legs, the folds of the legs, for example, back pain, body ache, and intense weakness. This is followed quite quickly within 1 to 3 days after the appearance of fever we see the skin eruption phase, and this is the very characteristic part of monkeypox. So usually the skin lesions are concentrated on the face and the extremities of the body rather than the trunk, although in severe cases you do find the lesions all over. Here you can see in most of the cases, lesions are on the face and on the extremities, including the palms of the hands and the soles of the feet. Ulcers can also be seen in and around the mouth, on the genitalia for men and for women, in the eyes, and in very rare cases, a more invasive infection of the eyes. So the rash goes through what we call an evolution. So it grows from a baby lesion to an adult lesion. It's macules, which are the lesions with a flat base, and I'm going to show you a picture just now, so it'll be a little bit more clear. It develops into papules, which is the slightly raised lesion. It then becomes more of a blister that's got fluid in it. This progresses into a pustule, so that fluid becomes pussy, so it's a yellowish fluid that's contained in those vesicles, and then it will crust up, make a little scab, and fall off. And we'll look at a picture of that in the next slide. So the number of lesions, some people only have a few spots, even one spot, and other people have, in the severe cases, the body can just be covered with these spots from top to bottom. So here's just some pictures of this famous rash that we have been talking about in the last couple of days. On the left hand of the screen, you can see some of that pustules that we've talked about. So these are examples of the more mature skin eruptions. And then on the right-hand side of the screen, you can see the development of those spots over time, from early vesicles up to the point where the scab falls off. And of course, at this stage, once all of the scabs have fallen off from all of the lesions, then the person is no longer deemed infectious. Also note that at the same time, you can have lesions at different stages of eruption. So all of the lesions on the body won't necessarily look the same at any given point in time. So the good news is that this is, although it looks really horrible, it is a self-limiting disease, which means it's one of those diseases that most people, their immune system takes care of it, and there's not any hospitalization or medical treatment required. And this also without any long-term side effects. Usually the disease clears up within 2 to 4 weeks, depending on the severity of the rash. So by 4 weeks, you expect all of the scabs for all of the lesions would have fallen off by then. In the severe cases, we can see these cases usually in the endemic countries. Severe cases tend to be in children, and we do expect that any person with any form of underlying immunodeficiency may have a worse outcome. And then other complications of infections, like secondary infections, if you scratch the lesions too much, and you get bacterial infections and so forth. These are all things that the doctors need to consider when they're treating these cases. Case fatality rate varies, but as we've discussed already, at least for the West African clade, the case fatality rate is really low, and it's approximately 1%. What we also need to remember is not every case of somebody with a rash is the monkeypox. There's many other diseases that we find very commonly, for example, chickenpox, measles, syphilis, many causes of different bacterial skin infections. These may all cause rashes, and sometimes even similar rashes that our doctors need to consider now. Are we dealing with a monkeypox case or something that we just see every day? In terms of treatment and vaccines, again, because this is a self-limiting infection almost all the time, by far most of the cases don't need any specific treatment, and the infection resolves on its own. If there's any medical intervention required, it's usually just to help the patient to deal with the symptoms that they are experiencing, dealing with headache, body ache, maybe the itchiness of the rash. These are all things that the doctors can prescribe non-specific medications for to help the patient be more comfortable. When we look at vaccination, so currently there are no commercial vaccines available for monkeypox per se, but what we do know is that because we've got a history of vaccination against smallpox, and that the smallpox vaccine being up to 85% cross-protective for monkeypox, so these are viruses that are very closely related, there would be some level of residual immunity in persons that were previously vaccinated for smallpox. Now, across the globe, most countries stopped smallpox vaccination by 1980, and in South Africa, that's the same. So you will expect people that are 40 years and older to have been vaccinated for smallpox and to have some sort of residual memory immunity that could assist with tolerating a monkeypox virus infection. So even a milder course of infection if such an individual would be infected. There are vaccines available internationally, again, not commercially. These vaccines are kept in stockpiles, and the access and the use of these vaccines are currently not clear. So I'm sure that the policy on the use of that vaccination, if it would be deemed important in the management of the current outbreak, would be shared in the coming days. From my own opinion, I think we can move quicker through contact tracing, monitoring, and isolation of cases than we would with vaccination in this particular instance and in this particular outbreak. So how do we aim to be prepared for any possible cases in South Africa? So steps have already been taken to increase, and we continue to take those steps as the international outbreak develops, of course. We are increasing vigilance and awareness in our healthcare workers. So we are equipping them with tools to help them to identify these cases and then to work with all the different role players within the public health sphere to deal with any cases if we would have those. So we are also giving guidance for response to suspected cases. How are we going to deal with it step by step? And then also guidelines for healthcare workers on how they would go about managing any confirmed cases if there would be the need to do that. We also have an established laboratory capacity at the National Institute for Communicable Diseases so that we can very quickly test any suspected cases and either exclude monkeypox virus disease or confirm it so that the public health responses to prevent further transmission of the virus in South Africa can be employed swiftly. So the NICD serves as a referral laboratory. So laboratories across the country, either from private or from the state facilities, have established ways to send samples to the NICD. This is routine for us, so we can really, from any corner of the country, investigate cases very quickly. There's more information available on our website. We continue to update the information, especially the risk inference for South Africa as the outbreak continues to develop internationally. So please keep your eyes on the website for updated information for South Africa. And I think that was my story, and I hope I can answer your questions.
Thank you so much, Dr. Weyer. We do have quite a number of questions from colleagues, and I presume some of them will still be coming through. So we have one question from Donato Mancini, and the question is, are we seeing any signs there may have been some degree of evolution in monkeypox. And then we've also got Reuters News Agency. We've got James there. He has sent us, I think, 6 questions. I'm just going to run through them and then we'll stop there to take another round of questions. Are people in Africa routinely vaccinated against monkeypox? I think you've covered that somewhat, but I think it'll be good to reiterate. Is it a disease that ordinary people in Africa know much about, or is this outbreak outside of Africa one of the first times many people in Africa would have heard about it? Is it possible to say the context, how many monkeypox cases were recorded in Africa last year and the year before? Does vaccinating against monkeypox make sense in Africa in the same way that some countries which currently have outbreaks are planning targeted vaccinations? Do the same vaccine inequity considerations that apply to COVID-19 apply to monkeypox? And finally, are there concerns that if vaccinations campaign in Africa are needed, the continent will be at the back of the queue? I'll hand over to you, Dr. Weyer.
I tried to scribble that down. You went very quickly, so I might just rope you in just to remind me of the questions, Sine. So the first question was to Natsu, evolution of the virus. So as I've mentioned, there's 11 of those cases that have been subject to full genome sequencing, and there's virtually no change of this virus over time. So here we are dealing with a DNA virus, and our experience with DNA viruses is that they actually don't mutate very quickly. They're very stable over time, and you can even find that these viruses have no changes over decades. So what we're seeing here, the virus or the cases that have been characterized further, of course, there are many more that still needs to be analyzed from those 11 that I've mentioned. This is West African lineage of the monkeypox virus that is involved in this outbreak. There's no changes from the viruses that have been recognized in recent years in Nigeria. So nothing strange, nothing that we haven't seen before, except that it's now happening in a different place. I hope that answers that question. The next question was vaccination, current vaccination in Africa. So there are no commercial vaccines available for monkeypox. There is monkeypox vaccines that have progressed through different stages of development, but nothing that we can order from a supplier today. And that's everywhere in the world. And then the smallpox vaccines are kept in stockpiles by different entities internationally. And that is was done simply as a backup of some sort, not necessarily to respond to monkeypox situation. It was kept as a backup for smallpox following the eradication of smallpox by 1980. So again, those vaccines are not commercially available, and access to those stockpiles, I haven't seen the final decisions on that. But again, with this disease and with the way that the outbreak is developing, I am somebody that always promotes vaccination, but in this instance, I think we can move quicker to bring the outbreak under control internationally, but also if we would have cases in South Africa, by just doing the classical containment approach for outbreak, and that is identifying all of your cases or contacts, monitoring them, and then isolating any confirmed cases so that you very physically almost interrupt the chain of transmission. I think we can do that quicker than we can do with vaccines. So now remind me of the second question. It was related to vaccine or vaccinations outside of Africa or cases outside of Africa. Sine?
Yes. So I think there's one question.
Cases of monkeypox outside of South Africa, or outside of Africa?
Outside of Africa.
Okay, so you've seen from my presentation, you can ask, tell me if you need me to flip that slide back. Apart from the current outbreak, there were 7 instances where cases were reported outside of Africa. In 2 of those instances, it involved, the one instance was just in monkeys. So this was the first time that it was recognized, and this was in Denmark at a research facility. Then we had the exotic pet trade related outbreak in the US in 2003. And then several instances since 2018 up until last year with exported cases involving travelers from Nigeria to Israel, Singapore, the UK, and the US. I think I've got all of them. The next question was it also about vaccination outside of Africa?
So I think I'll bring in Prof Cheryl just to address the issue of vaccine inequities. So we've got 2 questions with regards to that. Prof Cheryl, if you may step in for us, please. So do the same vaccine inequity considerations that apply to COVID-19 apply to monkeypox? And the second question is, are there concerns that if vaccination campaigns in Africa are needed, the continent will be at the back of the queue? Dr. Weyer has somewhat touched on it, but I think it's important that you make a comment as well.
Yeah, certainly. I think Jacqueline has really outlined the approach to how this should be managed, given the challenges around vaccine availability and the types of vaccines that are available. I think the strategy really, and just to emphasize, I think there was another question, if I could just answer that directly. The Department of Health has been fully informed of the current state of the outbreaks in multinational countries, and their approach essentially will be, as Jacqueline described, is, for example, to alert port health authorities, as well as to have their teams available. Because again, in South Africa, when we have specific outbreaks, there are teams available that will do, and I'm sure colleagues, you've read about the ring approach. In other words, we would certainly look to see and identify and track cases in a ring way. And again, if the vaccine is available, that's what they would add. But I think in South Africa, that's what the approach would be. Given that the numbers of cases, we do not expect them to explode. I mean, that certainly this is the largest outbreak we've certainly seen, but that may well have had to do with specific settings that allowed for these large numbers to occur. So coming back to the question about equity. So my sense again is that at this time, we don't really need mass vaccine campaigns. I think that's not necessarily appropriate. I also think in terms of the vaccine agenda as well, it's very different. I think we've got other diseases, other infections, whether it be virological or microbiological, that do need vaccines. So I think the priority, given that this disease, as Jacqueline has described, is not a highly pathogenic, deathly, leads to deathly outcomes, it certainly does do that. But I guess my caution would be that, yes, we need an agenda for what vaccines should be prioritized and how we approach that. Because again, there's a finite amount of financing that can go into vaccines. And therefore, we need to really take that into account. And so I understand the pressure and the need, and I understand the inequities that are certainly visible with regard to certain of the vaccines and its availability. But I think in this particular context, I think we just need to be cautious that, yes, we do need vaccines, but what are our priority list of vaccines? Thank you, Senator. I hope that helps.
Yes, thanks, Prof. While you're on here, I do have a question from Nogukanya Mtambo from Jacaranda FM, and I think it's a very pertinent one. So does this outbreak in SA, if it were to have cases in South Africa, pose a threat in the fight against COVID-19 and other diseases such as TB?
Yeah, so again, I think where Jacqueline has described the epidemiology, we don't expect large numbers of cases. So I think it's really important that we be vigilant and identify cases early on and interrupt the chains of transmission. I think that's going to be key. I think we are fortunate now in our current state with regard to this particular resurgence in terms of the numbers, that in fact the resources and availability will be there, I would think, in terms of the National Department of Health and its provinces, and to be able to manage these particular cases. Because as I said, we do not expect disruption of our health service were we to identify 1 or 2 cases. But if we do certainly see larger numbers of cases, that does pose certain constraints. But I'm hoping that given our experiences with regard to other diseases such as measles or polio, for example, that we'll be able to manage this appropriately. Thank you.
Thank you so much. Dr. Weyer, just a few questions for you. One from Storm Simpson, who is citing our update on the 23rd of May with regards to genital lesions. His question is this the first time patients have presented with genital lesions, or has it happened in previous outbreak? And then another question from Janice Q with regards to can someone who's asymptomatic still be capable of transmitting monkeypox, such as via semen or vaginal fluid?
All right, am I unmuted? Yes. For the first question, so it's certainly not the first time that we are seeing cases with genital lesions. I think, you know, it's almost similar to our experience with Ebola. With Ebola, we said this, and this, and then when we had the Western Africa outbreak, where we were dealing with greater number of cases and more data, we appreciated more features of the disease just because it was recorded for the first time, or it was experienced for the first time. So I think it's not a unique feature of this outbreak. Again, the viruses, as far as the ones that have been characterized so far that's involved in this current outbreak, it's not different from the viruses that have caused outbreaks in Nigeria and West Africa from before. I think there is just more data being collected, and we may be appreciating this feature of the infection more than we did before. I don't think it's a new manifestation of the infection. I hope that answers the question. Just come back to me if I need to elaborate more. The second question about asymptomatic transmission. So again, because historically, there's been so few human cases. I mean, monkeypox is not really a disease of humans. We are incidental hosts of the infection, and it will peter out over time even if you don't intervene. Asymptomatic transmission with monkeypox and other pox viruses have not been noted before in the human population. So it's really when that last scab from that last vesicle that person had falls off, that person is no longer considered infectious. Of course, this is a question that research could look at more specifically. So if we would have access to semen samples over time, this is a question that we can answer with experimental data rather than just epidemiological observations. So I hope that answers that question. So now back to you.
Thank you. I'm going to take 2 last questions, and I'm going to allow Dr. Weyer to make her closing remarks. Prof. Piran, if you could please take these ones. So as Dr. Weyer has indicated, monkeypox has been around for half a century. By the way, this question is from Janice Q. Until now, it's never sparked an international outbreak. Any ideas as to why now? And then we've got a question from Dennis Delport, who says he's noted a bit of panic. Should South Africans be worried about the disease, and what potential does it have to turn into a pandemic? Over.
Yeah, thanks very much for those key questions. My sense is that, yes, we've been noticing outbreaks, but in small numbers. I think there's still lots for us to investigate, I think, from an epidemiological perspective as to the specific setting or settings that has allowed for this larger outbreak to occur. It may well be events, and Jacqueline has already alluded to that, so-called super spreader events. It may well be a specific feature that needs to be investigated. And of course, it may well have been in circulation for longer than we thought in the UK, for example. And so there's been this accumulation and identification of cases, which I think is also added to our knowledge. So I think it's likely that there's better identification of cases. And I think we also need to understand what the settings were to allow for this initial series of transmissions to occur. With regard to South Africa, again, we know that Johannesburg and South Africa is a hub of international travel. So I think that is one of our risks that we do have, that there will likely be importation. However, I think my view is that, and I think Jacqueline may express that as well, is that given the nature of this particular disease, that we don't foresee that even though we may have cases, there won't be an establishment of this disease in South Africa. In other words, I don't foresee monkeypox becoming endemic in South Africa in terms of the explosive nature that we've seen with COVID-19. They're two very different viruses. We have to approach these viruses very differently with regard to using the same epidemiological tools, certainly, but certainly our approaches and our focuses on how to manage this, I think, is going to be very different. So I don't expect to see something like COVID-19 in terms of monkeypox at this time, given that I think from the initial data that's come from the genomic analysis, like I know it's genomic analysis, but there are no significant or major changes that says to us that there's great transmissibility of this virus or pathogenesis of this particular virus. So I think that those are some of the reassuring things so far, but I think we've got much to learn. So I'm going to hand over to Jacqueline for the final comments, if I may.
Thanks, Prof, for those insightful comments. And you've touched a bit on the risks to South Africa. And as Dr. Weyer is making her concluding remarks, I would like Dr. Weyer to touch on issues or questions that have come up around closing the South African borders. So that has come up quite often, and we've received questions even on our social media platforms and some media colleagues as well asking, why are we slow to close our borders when we see danger at our doorstep? Over to you, Dr. Weyer.
So internationally, there's been no travel embargoes or any countries closing their borders because of monkeypox. And maybe this is not the best example, but I'm going to use the Ebola example because I think a lot of people that are on the call have had experience and have some knowledge about Ebola since the West Africa outbreak. So it was a massive outbreak of Ebola, a highly fatal infection within West Africa. During the 3 years that outbreak was ongoing, we didn't close our borders and we didn't have a case. But we were prepared to deal with it if it would come our way. So also using Ebola as an example of a virus that spreads very differently, and maybe more similarly to monkeypox, but very differently from viruses like flu and viruses like COVID-19 that just goes global at large numbers very, very quickly. With the West Africa outbreak, 30,000 cases or more, because not all cases were confirmed within that region during the outbreak. A handful of cases were exported and we had no cases in South Africa. And the outbreak largely remained within West Africa. It tells you a little bit about how the virus behaves and how it's being transmitted. And it's the same for monkeypox. So with monkeypox, it's not a virus that's highly transmissible. It's not like COVID-19 at all. And we can get ahead of the outbreak by case tracing, monitoring, and isolation of cases, similar to what one can do with Ebola. I just wanted to use that example. And then maybe just another thought on the closing of borders. I think we're all acutely aware of the economic and the social impacts of such a decision. And I think it's always almost like a cost-benefit discussion that one needs to have. Even if we would have one case or two cases of monkeypox, our system would deal with that. And the cost of that would not be the same than closing the borders even for one day. So I think one needs to weigh up the risks and the benefits of the situation in an objective way. And I think that's what we're seeing in the global community as well. So it's not just for South Africa. No other countries have closed their borders or imposed travel embargoes on any countries to date. If the situation changes and there's a need for us to do that, of course, those decisions can change. Over.
Thank you so much. On behalf of all of us, Dr. Weyer, thank you so much for coming through today. I'd like to thank Professor Cheryl Cohen in her absence as well. Our Executive Director, Prof Cheryl, thank you so much for always availing yourself. And I also want to thank members of the media as well as the communications unit who works very hard behind the scenes to make these sessions happen. Prof, I'll let you say the last word.
Thank you very much, Zinjanda. Thanks, Jacqueline, as well, for elaborating on this important outbreak. And we hope that we won't be as markedly affected, but we wait to see. There's lots to learn from this particular outbreak. And I thank everyone for assisting us in informing the public, and I hope that was helpful. If you have any further questions, please do forward them to Zinjanda and a team, and we'll be happy to respond to that. So thank you for the opportunity for participating in today's event. Thank you.
Thank you so much. Have a good day, everyone.
Yes.